Hello, and welcome to today's episode of the Pediatric Consult. I'm Dr. Paul Bunch, a community pediatrician and your host for today. I'm very excited to talk to today's guests, Dr. Bobby Thikkurissy and Dr. Scott Schwartz, both from the Pediatric Dentistry Division here at Cincinnati Children's. Today's discussion is a consult on the use of fluoride in our patients. So, Dr. Thikkurissy, Dr. Schwartz, thank you so much for joining us today. First, let's introduce you to our listeners, let them get to know you a little bit, your background, some of your interests. Dr. Thikkurissy?
Sure. Thank you. Thanks for having us. I've been at Cincinnati Children's about 12 and a half years. And prior to that, I was at Ohio State University. I am originally from Southern California, did my dental training in New York at NYU, and my pediatric training at Ohio State University. I was also in the Air Force for 8 years and spent some time overseas as well. So I've been able to interact with pediatricians in a lot of different venues, and I've learned from all of them.
Yeah, coast to coast and around the world.
Yes.
Very, very cool. Dr. Schwartz?
Thank you for having us. I'm Scott Schwartz. I have been at Cincinnati Children's for about 9 years. I came here straight out of residency, which I completed at the University of North Carolina in Chapel Hill. And while I'm not thinking about teeth or fixing teeth, I am at home baking, tending to some houseplants, or just hanging out with my husband and our 4 greyhounds.
That sounds great. So today's topic is something that I think as pediatricians, we know some about, but we always want to know more. It's a topic that comes up in the news, it comes up on social media, and, as primary care docs, we want to be that trusted source of information. So, I think this is a good forum for us to learn more so that when we do get asked that question at a well visit or at a sick visit, we can give it a more intelligent answer. So, Bobby, are you able to talk a little bit first about fluoride, why it's important, what our body does with it?
Sure, absolutely. So fluoride is a naturally occurring element, and what it does in terms of the oral cavity of the mouth is it actually helps teeth be more resistant to breakdown. So when we eat or when we drink, our mouth pH drops and it becomes acidic. During certain periods of that acidity, our teeth essentially start to demineralize. So the enamel of our teeth starts to break away. Fluoride actually can get incorporated into tooth structure, can make teeth more resistant to breakdown. It does have a strong antibacterial effect. So the bacteria that causes cavities, all of that cannot metabolize fluoride. And so it actually has a very positive effect in terms of the microbiome and the bacteria within the oral cavity.
And, prior to the supplementation through various methods that we'll talk about, are there natural sources of fluoride that our bodies that we've depended on through the millennia?
So yes, so fluoride, originally the way that fluoride was kind of discovered to have this effect was in Colorado. In Colorado and in other mountainous areas, there is a higher than normal concentration of fluoride in the water. And so in the particular case of Colorado, there was what was known as the Colorado brown stain. And this was essentially fluorosis, so a higher level than we would want, that turned the teeth kind of brown. However, these teeth were also much more resistant and did not have cavities. So over the years, and it should be kind of underscored that fluoride in community water has been studied over 70 years. And during that time, kind of optimal concentrations have been determined. So we're not getting the Cincinnati brown stain or the Topeka brown stain, but instead we're getting an optimal level that gives us the benefit of preventing cavities, but also does not go into that toxic level.
That is a way more interesting answer than I thought I was going to get. I love it. The Colorado brown stain. Thank you. I did not know that.
Actually, and I will give Scott credit for this because I've listened to him over the years talk about fluoride, and he tells a really great story, which could be a podcast of its own, on the history of fluoride, because it takes a lot of unexpected turns. And it's really interesting how we've gotten to where we are. And I think one thing that it keeps resonating with me is this is something that has been studied for many years in many settings. Mm-hmm. And we have international data as well to kind of support the policies that have been done in the United States.
So, Scott, I'll turn to you then. If could you talk a little bit about that history? When fluoride was first introduced to the public water systems, how that has changed over the years?
Sure. So the Colorado brown stain that Dr. Bobby is mentioning was actually first discovered here in the United States in the early 1900s. So this is a topic of conversation that we've been having for 120 plus years. And from the early 1900s to the 1930s, this doctor, Dr. McKay, Frederick McKay, who was the first to identify this Colorado brown stain, had been called to various parts of the United States, to Idaho, where a community had just hooked up to a water supply, and they started noticing that their children were being born with this Colorado brown stain. He recommended they disconnect from that water supply, and as soon as they did, they started noticing that children who were just born did not present with the same Colorado brown stain. And then finally in Arkansas, there was an aluminum company that noted that they also had this similar appearance, and they wanted to verify that it was not the aluminum in the water, their wastewater, that was causing this problem. And so he came out to Arkansas, where they discovered that it was fluoride that was causing this problem. It went from being, kind of talked about in these communities to the NIH, where scientists at the NIH were able to identify fluoride down to the 0.1 parts per million, and then identify when fluorosis would be present, what would be beneficial to a population. So at the NIH, they're thinking, well, this was creating teeth that are resistant to caries, and how can we do this at a population level to really help people, more broadly speaking. And that is when the idea was hatched to fluoridate the water in Grand Rapids, Michigan. So in 1945, they were the first city in the United States to fluoridate their water supply, and many soon followed. Dr. Dean from the NIH was the epidemiologist who was involved in that, and he identified pretty rapidly that there was almost a 60% reduction in dental caries in that community when compared to neighboring Muskegon. And so from there, we kind of got to today with more and more communities fluoridating their water. And I'd like to mention that this was not happening just in a vacuum, that our dental friends from across the pond were noticing similar things in communities that had this naturally occurring fluoride, that they had stained teeth that were resistant to caries, but unesthetic, but otherwise healthy. And so from there, we've kind of gotten to this place today, where we are fluoridating communities to protect teeth at a population level.
And do we know what percentage of public water in the U.S. Is fluoridated currently in 2025?
About 73% of the United States population has access to fluoridated water. Some of those individuals are not using it. They're on private wells or get their waters from other sources. But the vast majority of Americans do have access to community water fluoridation.
Great. And then, a lot of times this question is going to come to us in the clinic with concerns about, the fluoride that's present. Can you guys talk a little bit about the controversies, the concerns that have arisen over the years, and kind of what the data has actually shown?
So the controversy has really been there almost from the beginning, and it has surrounded several different kind of concepts. One being this idea of forced medication, or not being able to consent to what is being given to you to treat your health. And also some other bodily concerns, calcification of the pineal gland, thyroid issues, lowered IQ is probably the most significant of our current time. And what we know about the controversy is that these studies, with the IQ piece specifically, is that these studies that have come out to show that fluoride has an effect on IQ, a negative effect on IQ, come from places where that water is naturally fluoridated at concentrations in excess of sometimes 100 times what we are using here in the United States in community water. So it's not really an apples to apples comparison. And the most recent controversy has come in the last year. The National Toxicology Program in the United States released a report that stopped just short of saying that fluoride is a known neurotoxin and can negatively impact the IQ of children. And what you find by digging just a bit deeper into that is that none of those studies were produced in the United States. All of those studies focus on concentrations of fluoride. All of those studies focus on concentrations of fluoride that are well beyond what we are using here in the community. And the little asterisk at the end of that study was that there's no good data to say whether or not how water is fluoridated in the United States, whether or not that has an impact on IQ. But that, of course, nobody's reading to the bottom of the page. They just are looking at the headlines. So the concern, I think, is there in some of these communities internationally specifically where there's high concentrations of fluoride, but here in the United States, and not really too much of a concern from that end.
So it really just goes to that point of the toxicity is all about the dose. And
Exactly.
anything can be toxic at certain doses. So.
And I think that when we have these conversations with families, we try to be inclusive of that family's philosophy. So if a family comes in and they are against kind of artificially supplementing with fluoridated water, we will take a step back and we will say, well, fluoride is one part of keeping the mouth healthy. So what else can we look at to ensure that kids are cavity-free and healthy and free from pain? A lot of times that falls back down to diet and then just basic oral hygiene. So are they actually brushing teeth? Are they in there brushing? Do they have a dentist, a dental home that they've established? And our goal in the American Academy of Pediatric Dentistry is that by age 1 or by the 6 months with interruption of the first tooth, they have a dental home, someone who will be able to help that family kind of guide through the developmental stages.
And Dr. Scott, you had mentioned that 73% of the U.S. has access to fluoridated water, so that leaves another 27%, whether that's well water, non-city, non-municipal sources. What are the recommendations for those families if we have patients who are on a well system, or maybe they're primarily drinking, bottled water or water from a water cooler? Like, how does that all come into play with our recommendations?
Sure. So first, I'd say, as Dr. Bobby mentioned, fluoride is just one component of this. So if you're not going to be getting fluoride in your water, then we need to maximize some of these other preventive aspects of your oral healthcare regimen. But we can actually add fluoride to water currently, can actually add fluoride on our own in the form of tabs or drops. So if, there is a patient who is known to have unfluoridated water, there are ways that you can send samples to a lab to have them evaluate that water and tell you how much fluoride is in it. Because if you're on a well, there is actually a risk, right, that you're getting water that is has too much fluoride. So it's probably to the benefit of the family to understand what is coming from their tap, wherever that source might be. And if it is found that there is no fluoride or low levels of fluoride in the water, these fluoride supplementation tablets or drops can be very beneficial to help prevent caries. And I think one thing that we're kind of talking around here is that fluoride comes in many forms. And so the community water fluoridation prevention aspect is systemic fluoride, but that topical fluoride that you're getting from toothpaste or from fluoride varnish at either the physician or the dentist's office are other exposure points to fluoride that can be beneficial even if it's not in a systemic sense.
So let's talk about toothpaste, because I know in my career, I've been out practicing for 13 years now, that recommendation has changed for when to introduce a fluoride-containing toothpaste. So can you guys talk a little bit about what the current recommendation is on the use of a fluoride-containing toothpaste, what age you would recommend that, and maybe why that recommendation changed a few years ago?
So I think one thing that, and you hit on it earlier, which is it's in the dose. That's the main issue. So one of the controversies that's surrounded that dose is if you watch TV, if you look at print ads, there's usually a big ribbon of toothpaste on the toothbrush. And it's rare that even as adults, we use that much toothpaste. So the recommendation, again, from the AAPD is for children 3 and under, we are using a grain of rice size amount of toothpaste. So it's a very, very small amount. For children 3 and up, it is a pea size. So it is the amount of toothpaste that is used, which is another reason that we really encourage parents to be supervising when children are using toothpaste to make sure that they're using the appropriate amount. Unfortunately, fortunately, children's toothpastes are very flavored and very sweetened. And if you've ever tried them, there's a fine line between that and candy almost. So younger children in particular, may want to use more because they like the taste. The reality is, in terms of the fluoride concentration, there's no difference between a child's toothpaste and an adult toothpaste. So that flavoring really is mostly marketing, and a lot of it, cartoon characters, et cetera.
Mm-hmm.
So we really encourage families are supervising how much toothpaste. And really, children don't spit effectively till they're about 6 years of age on average. So whatever we give the 3-year-old, they are going to probably swallow more than they spit out. So that is why the dose recommendation is that grain of rice size of toothpaste. And typically, if you go to a dentist appointment or dentist office, they can show you, and we do that with our patients, is we'll actually take the cap off the toothpaste and show them. And I would say 95% of the time, parents are shocked at how little is really needed to be effective. So I think there's also that messaging there on how much is truly needed.
I think to kind of build on what Bobby has mentioned here, the recommendation is to use fluoride toothpaste as soon as the first tooth erupts into the mouth. And this grain of rice size, I joke that, are we talking about brown rice or basmati rice or, what have you? And I'm even more specific sometimes to say that it should be just enough to cover 2 bristles on that toothbrush. And to Dr. Bobby's point, parents are shocked. I think many people are shocked to see how little toothpaste can be effective. One thing along these lines to discuss would be also training toothpaste, because there are lots of companies now that are marketing fluoride-free toothpaste or training toothpaste. And while it might taste good or it foams just like your regular toothpaste, you're mechanically removing that plaque from your teeth. Toothpaste in and of itself does not have a protective quality against caries unless there is fluoride in it. So the mechanical disruption of plaque is important to keep your gums healthy, and certainly to minimize the amount of bacteria in your mouth that are creating cavities. But just removing it alone without fluoride or something to help prevent caries in the future is not going to provide a massive benefit. So training toothpaste can be good for your 3-nager who really wants to brush on their own and is independent, and give them the chance to do that first. But a caregiver supervisor should always come through with the real stuff and make sure that those teeth are getting nice and clean.
3-nager?
A 3-nager.
3-nager. I have not heard that term before.
It's the graduation
yes.
You go from terrible 2s to 3-nager.
Yes.
So for those kids who cannot effectively spit till 6, what do you guys recommend as far as giving them water to help dilute the fluoride, or does the parent need to try to wipe the teeth down? Are there ways to minimize that unintentional fluoride ingestion?
So actually what we are telling parents is that small amount, and again, we're showing them that amount, if left on the teeth and any excess is swallowed, it's not going to harm the child. Yeah. So we actually recommend not rinsing, because essentially you are getting a topical fluoride treatment overnight while the child is sleeping. And that does bring in another interesting point, which is when we have our children who are on chronic medications, ideally those children are taking those medications 30 minutes before we're brushing the teeth. And brushing the teeth is the last thing we do. Mm-hmm. And the reason for this is many of the medications are very high in sucrose. And because we want children to be compliant, so the medicine is meant to taste as good as possible. But if that medicine is staying on their teeth all night, it's having the same effect of exposing the teeth to sugar.
Okay. And I think the whole idea of a small enough amount that's not going to cause damage or fluorosis brings me to my next question, which is, what are the risks of too much fluoride? Chronically swallowing just a little bit too much every day, higher than ideal levels in the water. What kind of things can we see with fluorosis or other complications?
So even
What's it even look like?
Sure. So even with our community water supply fluoridated at 0.7 parts per million, which is the CDC's recommendation, you can still see fluorosis, and that happens in about 10 to 12% of the population. It is not the Colorado brown stain. It is not that type of fluorosis that we're talking about. And for many of those patients, honestly, the fluorosis that they have, they might not even perceive. And it might be something that we as dentists note because we are doing an exam of their teeth and notice, in its mildest form can be more white, chalky appearance to your tooth, more in the central body of the tooth. And then it can progress from there to some pitting, and then you get into this brown, creamy, yellow stain that can happen if too much is incorporated. So, and that, to clarify, is from the systemic incorporation into your developing permanent teeth. So that would primarily come from too much water or too much fluoride in your water. Swallowing the appropriate dose of fluoridated toothpaste every day, from Bobby's point, is going to have minimal impact in terms of systemic health. Too much of it, however, you walk into the bathroom and your kid has, toothpaste all over their face, it's all over the wall. You have no idea how much they've actually consumed. There are CNS type issues to be concerned about at a very high dose. Fluoride likes to bind to calcium. That's part of the reason why it helps to remineralize our teeth. And so it can cause imbalances in electrolytes that can lead to tetany and these things. But that is, like I said, your kid has swallowed the entire tube of toothpaste. Mm-hmm. For the most part, it's GI upset and some vomiting that's associated. And so to that end, if there is a suspected overdose, the first thing to do would be to call poison control. Do not induce vomiting, and to give your kiddo a tall glass of milk or a yogurt to help chelate some of that fluoride that's circulating or will eventually be circulating out of the GI tract.
And then for those communities that have those naturally occurring high levels of fluoride, like Colorado, do they remove fluoride in their water purification process? So they'll actually go the other way and pull it out?
Yes, the whole point of it going through a water treatment facility is to equilibrate the amount of fluoride in addition to, the chlorine and other things that they add to the water to make it as safe as possible for us to consume. Yep, so that definitely goes both ways.
So for over 100 years, we've known that adding fluoride to the water can be beneficial to dental health. What happens when it goes the other way, when the fluoride is no longer put in the water? Has that been studied?
We actually have a fair amount of recent examples of this, actually. Probably the most well-published, well-studied at this time is a study from Calgary, Canada. That city voted to remove fluoride from their water supply. It was a combination of aging infrastructure and this concept of forced medication. And by voter referendum, they removed it from the water supply. And over the course of the next 10 years, they found that there was an increase in caries, increase in cost, dental, medical related costs, increase in general anesthesia for children who had severe early childhood caries and needed treatment. So they actually went back and voted again to add fluoride back to the water supply because they had seen such significant detrimental dental effects. And as it goes, it was not any cheaper to fix the infrastructure or to re-implement the infrastructure at that time. And that's not the only city that we have this data from. In that situation, in neighboring Edmonton, they found that, which was still fluoridated, their caries rates were staying at a similar level. So this happened also in Juneau, Alaska. They removed fluoride from the water, noted a massive uptick in caries and dental-related costs, and also in Windsor, Canada. So we do have examples of it being removed from the water supply and some of the detrimental effects that come from that. And thinking about a lot of people say in Europe and other countries, they're not fluoridating their water, so why should we have to? And that's not entirely true. There are quite a few countries, New Zealand, Singapore, Brazil, parts of the UK and Spain and others that do fluoridate their water. There were 11 European Union countries that used to and then stopped. And it was never, all but two, I believe, were for not safety-related reasons. Again, this infrastructure, situation, cost, et cetera. But I think the nuance there is that there's also some other forms of fluoride in these European countries. In the same way that we iodize salt, they fluoridate milk, have greater availability of fluoridated water. But what we know is that even though they have these alternative sources, because it's not this consistent access to fluoridated water, that the caries preventive effect of those interventions is not as good as the community water fluoridation itself. And of note, I will say that while caries rates in children and adolescents in the EU have been decreasing, a recent World Health Organization report actually noted that there was an increase in caries in adults. And so the thing about community water fluoridation that we know, it's one of the greatest public health achievements of our time because it is egalitarian, everybody benefits, and our vulnerable communities are certainly benefiting the most.
That's so interesting, just how many natural experiments have kind of arisen out of, public health concern, political pressures, but we get these natural control studies and can learn a lot from them. So,
Sure.
Yeah. So we've talked about systemic fluoridation of water. We've talked about toothpaste. There's one other tool that we can use, which is fluoride varnish. Bobby, could you talk a little bit about what fluoride varnish is, when it's recommended, how it's applied?
Sure. So fluoride varnish is a much more concentrated form at 22,500 parts per million. So significantly higher than toothpaste and what we would get in community water fluoridation. What we have done is we typically professionally apply that twice a year at our cleaning appointments. There is a increased substantivity of that fluoride during that initial period. When I was a kid, we had the old fluoride foam trays that you had to put in, and you had to chew on the trays while you sat there gagging and everything. We have moved beyond that to this varnish, which is increasingly becoming more consumer friendly. There are kind of water-based forms of this that go on very thin and can impart a lot of that fluoride protection. Interestingly, and I think Scott has insight into this as well, is this is now a physician billable code. Mm-hmm. So this is a code that can be used by physicians as part of their practice. And in an ideal world, children, particularly those at high risk, are getting these fluoride applications at all well child visits, medical and dental, so that there is kind of this consistent preventive coverage.
So it's recommended twice a year, and is that correct? Every 6 months, or you're saying every well visit?
I mean,
which is
I would say every well visit. I don't think there is a limit established, Scott.
Okay.
No, but we typically are doing our visits twice a year, every 6 months.
Yeah.
Now the difference there is we have some families where the risk of disease is so high, we may see them on a more frequent basis. So we may see them every 3 months. We are still doing fluoride application at those intervals.
Okay. So there's that benefit to that even more frequent application to higher risk.
And yeah, exactly. Like we were mentioning earlier, it's integrating into the tooth structure. It's actually interfering with bacterial metabolism that causes disease. So it has multiple benefits.
And for the medical providers who have never done fluoride varnish before, can you guys talk through briefly like what that process looks like, what steps you have to take to apply the fluoride varnish?
Sure. So I think the key to fluoride varnish application first would be dry teeth. And so it can be helpful to have an extra set of hands. And the second key is to have the patient in the correct position. I talk to a lot of physicians about fluoride varnish applications, a lot of residents about this. And I think often without a lot of education in this area, there's a sweet baby sitting up on an exam table and you are sitting directly across from it as if you were, having a conversation, and you reach over with your brush and try to get that into their mouth, and they're just backing away and start to get upset. And I think that that's just not going to be effective. And as Bobby mentioned, there's 22,500 parts per million fluoride in this tiny little packet. So to have a child swallow all of that, you want to make sure that you're applying it correctly. So what we use often in our clinic is a knee-to-knee position. And so the provider and the parent are sitting with their knees touching. The parent has the baby chest to chest with them with their legs wrapped around their hips. And then when everybody's ready, they can tip the baby back into the provider's lap, who then is looking down at the patient just like we do at the dental office. And that's just the most favorable position, if you had concerns orally about a child, to examine their oral cavity, but B, to apply fluoride varnish. And you would use a 2x2, 4x4 gauze to dry a section of teeth and then paint a thin layer on all surfaces of the teeth, and then complete that throughout. It's important to read the instructions for use for any of the fluoride varnishes that you may purchase. As Dr. Bobby mentioned, we're trending to this more water-based, thin, more palatable product. In the old days, you couldn't brush for 6 to 8 hours. Now you can't eat for about 15 minutes, and then you can brush that evening, et cetera. So important to be aware of the product that you're using.
And we do this in our office, and I find that knee-to-knee position, especially the younger toddlers, not so much the preschoolers, as soon as you lay them back onto your knees, they start screaming at you.
They sure do.
And it's a perfect position. And I thank them for opening their mouth so wide.
It's a very nice
as they
view.
Scream at me. Yes.
You have to get crafty when they start to get wise and they know exactly what's about to happen. So then they don't scream because they don't want the fluoride varnish. But yeah, they know what's up.
I found it to be a very quick procedure. We do it at the end before their vaccines, if they're due for vaccines at that visit, and it usually goes pretty well. Are there any national resources you guys can point towards that pediatricians can look at from the AAPD or the AAP or other learning modules?
The AAP has a really great section on oral health that has a lot of resources for a variety of dental-related topics, not the least of which is incorporating fluoride varnish into your practice with some instructions on positioning and product, but also how to bill for that code. So I think that the AAP is a great place to start, and certainly at the AAPD as well.
And, I will comment that something you mentioned earlier, which is physicians doing this, parents typically have a trusted relationship with their pediatrician, and they've come to you for, throughout all the well-child visits. And I think it really speaks to physicians being able to provide a whole child concept, that the mouth is just another part of the body that requires care and assessment. And a lot of times when we talk to physicians, it is really elevating to them what are the situations that need immediate treatment, immediate management. Because the reality is most physicians get about an hour in med school on the mouth, and the teeth are typically what you look past to look at the tonsils. Mm-hmm. So it's not something that physicians are readily equipped. It would be akin to Scott or I diagnosing a hernia off of the way a child coughed or something. So I think the integrating and connecting with dentists in your area is always useful. Most pediatric dentists are happy to connect with pediatricians. If you go to that aapd.org site, there's actually a Find a Pediatric Dentist area where you can put in a zip code, a mile radius, mm-hmm. and it will give you pediatric dentists in the area. So I think that's also a tool that pediatricians can use if they are unsure about things.
So in addition to physicians having the ability to apply fluoride varnish and get paid for it, recently silver diamine fluoride has been approved for medical providers to apply in their clinical setting. And I just want to give a brief word about this because it is not quite as innocuous as fluoride varnish is, in the sense that there can be some negative outcomes from its inappropriate use. So what silverdiamine fluoride is, it really is a wonder drug for us in pediatric dentistry specifically, is a medication in which the silver kills the bacteria that is causing dental caries. The fluoride is what's helping to remineralize the tooth. It can be a pause button at its worst, but at its best, it can completely arrest the caries process and prevent that lesion from progressing into the dental pulp and causing pain and infection. The major caveat is that it turns any incipient lesion or frankly cavitated lesion black. And so without careful diagnosis and understanding of what incipient caries look like and how to diagnose that, a physician who's applying silverdiamine fluoride might inadvertently turn 20 teeth black instead of just the single tooth that they were intending to treat. So I would say that, whereas fluoride varnish, you can apply it pretty freely, and as long as the kid's not swallowing a boatload of it, there's minimal downside. Silverdiamine fluoride is a wonder drug, like I said, but it does have some negative sequelae. So if there are physicians or other providers who are interested in its use, I would say connecting with a pediatric dentist to kind of walk through what that looks like and talk about its most appropriate use would be beneficial.
Well, Dr. Thikkurissy, Dr. Schwartz, thank you guys so much for your time today. I've learned a lot. For our listeners, we're going to link in the show notes to that AAP oral health guidance page. Today's episode is available for CME. You can find the link for that in the show notes as well. Dr. Thikkurissy, Dr. Schwartz, thank you very much, and I hope everybody has a great rest of your day.
Thank you.
Thank you.